Hello guys. So as I promised, I will be back in 2 hours, and I am okay. So today now we are going to learn about the pathology, cell injury, second type, tissue necrosis, apoptosis, and some bit of inflammation. Okay, so let's begin. This is simple topic, so we will see. Okay. So what is inflammation? So inflammation is a protective response involving host cells, blood vessels that is intended to eliminate the initial cause of cell injury, as well as the necrotic cells, and to initiate the process of repair. Without inflammation, infection would go unchecked and would never heal. Okay. Inflammation is defined as local response of living tissues to injury due to any agent. It is a body defense reaction in order to eliminate or limit the spread of injurious agent, followed by removal of necrosed cells and tissues. Aim of inflammation, destroying or neutralizing a harmful agent, example microbes, toxin, and necrotic cells. Inflammation, clinically denoted by suffix itis. Example is dermatitis, inflammation of the skin; arthritis, inflammation of the joint; hepatitis, inflammation of the liver. So, inflammation is a distinct from infection, while inflammation is a protective response by the body to variety of etiologic agents, infectious or non-infectious, while infection is invasion into the body by harmful microbes and the resultant ill effects by toxins. Inflammation involves two basic processes with some overlapping: early inflammatory response and later followed by healing. Though both these processes generally have protective role against injurious agents, inflammation and healing may cause considerable harm to the body as well. Example: anaphylaxis to bites by insects or reptiles, drugs, toxins, atherosclerosis, chronic rheumatoid arthritis, fibrous bands, and adhesions in intestinal obstruction. So, infection causes or the etiology of acute inflammation. Infections, bacterial, viral, fungal, parasitic, are among the most common causes. Trauma, various physical and chemical agents, example thermal injuries burns, irradiation, toxicities from certain environmental chemicals, foreign bodies, splinters, dirt, crystal deposits. Tissue necrosis from any cause, including ischemia, as in myocardial infarct, and physical and chemical injury. Tissue necrosis always follows by inflammation. Okay. Goal: eliminate necrotic tissue. Chemicals: glucose, fatty acid, toxins, alcohol, chemical irritants, including fluoride, nickel, and other trace elements. Immune reaction also causes a hyper sensitivity reactions against environmental substances or against self tissues. So, there are five cardinal signs of the inflammation: heat, redness, swelling, pain, and loss of function. Repeat after me: heat, redness, swelling, pain, and loss of function. Heat in Latin we call it calor, redness, rubor, swelling, tumor, pain, dollar, and loss of function, functio laesa. So, heat, redness, pain, then this loss of function and swelling. Right? Hmm. So, heat, redness, pain, sorry, heat, redness, swelling, pain, loss of function. Okay. Heat, color, pain, dollar, okay, color, dollar, rubber, tumor, and functional. वापस heat, color, then there is a heat, color, then redness, rubber, tumor. Okay, rubber, redness, rubber. Heat color, redness, rubor, swelling is a tumor, tumor, swelling tumor, pain, dollar, and pain, loss of function, functionalism. Heat, redness, swelling, pain, and loss of function. Heat, redness, swelling, loss of function, and pain. Okay. These manifestations occur as a consequences of the vascular changes and leukocyte recruitment and activation. So five cardinal inflammation: heat, redness, swelling, then pain and loss of function. See. So, features of acute and chronic inflammation. Acute inflammation is rapid in onset and of short duration, lasting from a few minutes to as long as few days, and is characterized by fluid and plasma protein exudation and predominantly neutrophil leukocyte accumulation. Chronic inflammation may be more insidious, is of longer duration, days to years, and is typified by influx of lymphocytes and macrophages with associated vascular proliferation and fibrosis scarring. Feature: onset, acute is fast, minutes or hours, and chronic is slow, day. Cellular infiltrate mainly neutrophils, and in chronic we have the monocytes, macrophages, and lymphocytes. Tissue features: tissue injury, fibrosis, usually mild and self-limited, and in chronic we have the often severe and progressive. Local and systemic signs: the acute is permanent and chronic is less permanent. Advantage of inflammation. Inflammation usually functions in a beneficial manner. It serves to destroy, dilute, or wall off the injurious agent, remove necrotic debris and other exudates, prepare the remaining tissue framework for tissue repair. Disadvantage of inflammation. Often accompanied by local tissue damage, may underlie some life-threatening hypersensitivity reactions to insect bites, drugs, and toxins. Sometimes associated with common chronic diseases like rheumatoid arthritis, atherosclerosis, and Crohn's disease. Mechanism of inflammation, vascular changes. Yeah. See, this is like a series of like events. So first of all, there is a damage to endothelium. Okay. So there is damage to endothelium, so what happens at the so what happens whenever there is a damage to the endothelium, damage to the endothelium, the this damage causes the mast cells which are located in the tunica media of arteries to release the histamine and other pro-inflammatory mediators. Okay, so histamine causes the vasoconstriction, sorry, vasodilatation, arteriolar vasodilatation, increased blood flow. Okay, so this so because of the increased blood flow, what happened that there is a redness in the area. Okay, and there is heat also produced, and hmm, increase vascular permeability, increasing outflow of water from the blood into tissues called as the exudate and edema, and this causes the swelling of the tissue. So increased vascular permeability leads to movement of protein-rich fluid and even blood cells into the extravascular tissues. This in turn increases the osmotic pressure of the interstitial fluid. The resulting protein-rich fluid accumulation is called an exudate. Exudate must be distinguished from the transudates, which are interstitial fluid accumulation caused by increased hydrostatic pressure, usually a consequence of a reduced venous return. Transudates typically contain low concentration of protein and few or no blood cells. Okay. Fluid accumulation in extravascular spaces, whether from an exudate or transudate, produces tissue edema. Exudate versus transudate. So exudate is the inflammatory fluid, and transudate is the non-inflammatory fluid. And total protein more than 300 gram per liter, and in transudate it is less than 10 gram per liter. And protein as plasma and practically all albumin. Okay. Fibrinogen present, so clot is found. No, not present, no clot. Okay. Plenty of inflammatory cells, neutrophil or lymphocytes, a few cells may be present. Specific gravity more than 1.020, specific gravity is less than 1.012. Mechanism of inflammation. The appearance of inflammatory edema due to increased vascular permeability of a microvascular bed is explained on the basis of a Starling's hypothesis. In normal circumstances, the fluid balance is maintained by two opposing set of forces. Forces that cause outward movement of fluid from microcirculation, forces that cause inward movement of a interstitial fluid into circulation. Whatever whatever small fluid is left in the interstitial compartment is drained away by lymphatics, and thus no edema results normally. However, in inflamed tissue, the endothelial lining of microvasculature becomes more leaky. Consequently, intravascular polar osmotic pressure decreases, and osmotic pressure of the interstitial fluid increases, resulting in excessive outward flow of fluid into the interstitial compartment. So, in acute inflammation, normally non-permeable endothelial layer of microvasculature begins leaking. Okay. Several mechanisms may contribute to endothelial cell contraction, leading to intercellular gaps in post-capillary veins is the most common cause of increased vascular permeability. Okay. Endothelial cell contraction occurs rapidly after the binding of histamine, bradykinin, leukotrienes, and many other mediators to specific receptors, and is usually short-lived. A slower and more prolonged retraction of endothelial cells resulting from changes in cytoskeeleton may be induced by cytokines like tumor necrosis by TNF and interleukin 1 IL-1. This reaction may take 4 to 6 hours to develop after initial trigger and persist for 24 hours or more. Okay. So, steps of inflammatory response. Uh, Recognition of injurious agent, recruitment of leukocytes, removal of the agent, and resolution repair. Recognition of microbes, necrotic cells, and foreign substances. How cells recognize the presence of harmful agents. Microbes and dead cells elicit danger signals that distinguish them from normal tissue and mobilize the host response. Phagocytes, dendritic cells cells in connective tissue and organ that capture microbes and initiate response to them. And many other cells epithelial cells express receptor. They express receptors that are designed to sense the presence of infectious pathogens and substances released from the dead cells. These receptors have been called pattern recognition receptors because they recognize structures, that is, molecular patterns that are common to many microbes or to dead cells. Sorry. Toll-like receptors are microbial sensors. Toll-like receptors are located in the plasma membranes and endosomes, so they are able to detect extracellular and ingested microbes. The inflammasome is a multi-protein cytoplasmic complex that recognizes product cells like uric acid and extracellular ATP. Recognition of microbes by these receptors. Mediated chemotreatment and certain cytokines affect this process by modulating the surface expression and binding affinity of the adenosine molecule and by stimulating directional movement of the leukocytes. Now, cellular event, leukocyte recruitment and activation. An important function of the margination and rolling along the vessel, adhesion to the endothelium, transmigration between endothelial cells, and migration to margination and rolling. First step of the inflammation vasodilation, which slows blood flow and cells marginate from the center of the cell to the periphery because the smaller RBCs tend to move faster than the larger white blood cells. Leukocytes are pushed out of the central axial column and thus have better opportunity to interact with the lining endothelial cells. This process of leukocyte accumulation at the periphery of the vessel is called as a margination. Rolling. If the endothelial cells are activated by cytokines and other mediators produced locally, they express adhesion molecules to which leukocytes attach closely. These cells bind and detach and thus begin to tumble on the endothelial surface, a process called rolling. The weak and transient interactions involved in rolling are mediated by the selectins. The three members of this family are E-selectin, axon, and the P-selectin. ठीक है. Adhesion. So the ruling leukocytes are able to sense changes in the they are able to sense changes in the endothelium that initiate the next step in the reaction of leukocytes, which is from adhesion to endothelial surface. This adhesion is mediated by integrins expressed on leukocyte cell surface interacting by the ligand on the endothelial cell. Integrins are activated by TNF and interleukin 1. Integrins they are glycoproteins that mediate the adhesion of integrin. Okay. They are normally epsilon. Okay. Chemokines are chemo-attracting cytokines that are secreted by many cells at site of inflammation and are displayed on the endothelial surface. When the adherent leukocyte encounter the displayed chemokine, the cells are okay. So see, first of all, this leukocytes have the integrins. They have integrins in normal state also, but the thing is that they are not activated. Okay, they are they are they are they are they are they are in the active form when they are in the active form when there is a stimulus of chemokines. So then they become active and the integrins. So integrins are the glycoprotein that mediate the adhesion of glucose to the endothelium. Transmigration: after being arrested on the endothelial surface, leukocytes migrate through the vessel wall primarily by squeezing between cells at endothelial junction. This extravasation of leukocytes called diabetes. Migration of leukocytes is driven by chemokines produced by okay. We stimulate movement leukocyte toward the okay. After passing through the endothelium, the leukocytes secrete collagenases that enable them to pass through. Okay. So in most forms of in first 6 to 24 hours, neutrophil is abundant, and in the next 24 to 48 hours, monocytes are abundant. So phagocytosis consists of three steps: recognition and attachment of the particle to the ingesting leukocyte, engulfment with subsequent formation of a phagocytic vacuole, and killing and degradation of ingested material. Leukocytes bind and ingest most microorganisms and red cells by means of specific surface receptors. Some of these receptors recognize components. Opsonization, the most important option, IgG antibody, immunoglobulin. Hmm. Killing and degradation of phagocytous microbes. The culmination of phagocytosis of microbes is killing and degradation of initial particles. The key steps in this reaction are production of microbicidal substances within lysosome and fusion of a lysosome with phagosome, thus exposing the ingested particles to the destructive mechanism. The most important microbial substances are reactive oxygen species (ROS) and lysosomal enzymes. Because glucose are capable of secreting potentially harmful substances like enzymes and ROS, reactive oxygen species. They are important causes of injury to normal cell and tissue under several circumstances. As part of a normal defense reaction against infectious microbes, when bystander tissues are injured, in certain infections that are difficult to eradicate, like tuberculosis and some viral diseases. The the host response contribute more to pathology process than the okay. As a normal attempt to clear damaged and dead cells, example after a myocardial infarction, in an infarct, inflammation may prolong and exacerbate the injuries consequence of the ischemia. Defects in leukocyte function. Since leukocytes play a central role in host defense, defects in leukocyte function, both acquired and inherited, lead to increasing susceptibility to infections, which may be recurrent and life-threatening. The most common causes of defective inflammation are bone marrow suppression caused by tumors or treatment with chemotherapy or radiation, resulting in decreased leukocyte numbers and metabolic diseases like diabetes causing abnormal leukocyte function. Defects in leukocyte adhesion in leukocyte adhesion deficiency leads to impaired leukocyte adhesion. Defects in phagolysosome formation. Outcome resolution, regeneration and repair. Repair. Okay. When the injury is limited or short-lived, when there has been no or minimal tissue damage, and when the injured tissue is capable of regenerating, the usual outcome is the restoration to structural and functional normalcy. Before the process of resolution can start, the acute inflammatory response has to be terminated. This involves neutralization, decay, or enzymatic degradation of various chemical mediators, normalization of vascular permeability, and cessation of immigration with subsequent death, acutasis of extravascular neutrophils. Furthermore, leukocytes begin to produce medicines that inhibit inflammation, thereby limiting the reaction. Necrotic debris, edema fluid, and inflammation are cleared by phagocytes and chronic inflammation may follow acute. Uh, Scarring is a type of repair after substantial tissue destruction, as in abscess formation, or when the inflammation occurs in tissues that do not regenerate, injured tissue is filled by in organs in which the extensive tissue deposition occurs. Morphological patterns of organ inflammation. So, serious inflammation is carried by outpouring of watery, relatively protein poor fluid that depending on the side and the plasma skin distribution. Fibrinous inflammation occurs as a consequence of more severe injuries, resulting in greater vascular permeability that allows larger molecules like fibrinogen to pass the endothelial barrier. Histologically, the accumulated extravascular fibrin appears as an eosinophilic mesocarditis. The fibrin exudate is a characteristic of inflammation in lining of body cavities like meninges, pericardium, and pleura. Such exudates may be degraded by fibrinolysis, and accumulated debris may be removed by macrophages, resulting in separative purulent inflammation and abscess formation. These are manifested by coagulation, several staphylococcus are more likely to induce pyogeny. Abscess and focal are focal collections of pus that may be caused by seeding of pyogenic organisms into tissue or by secondary infection of necrotic foci. Because of the underlying tissue desiccation, the usual outcome is scarring. Abscess. Okay. Ulcer. An ulcer is a local defect or excavation of the surface of an organ or tissue that is produced by necrosis of cells and slowing shedding of a necrotic and inflammatory tissue. Ulcers are most commonly encountered in the mucosa of mouth, stomach, intestines, or genitourinary tract, and in the subcutaneous tissues of lower extremity in older persons who have circulatory disturbances predisposing affected tissue to extensive necrosis. Ulceration are best exemplified by peptic ulcer of stomach or duodenum in which acute and chronic coexist. Mediterranean so histamine sources mass basophils and platelets. Vasodilation. Serotonin platelets vasoconstriction. Vasodilation. Okay. Plasma protein derived inflammatory complement plasma protein. Kinase. G. Cell derived Prostaglandins in leukotrienes. 1 minute, 5 minutes, guys. Just 1 minute. Bye, guys.